short. Good morning, everyone, and thank you, Kochi and AIOS, for having me here. I'll be speaking on the topic of treatment protocols in retinal vein occlusion. I have no financial disclosures to make, and these are the outlines which I'll be talking on. And as we know that it is the second most common retinal vascular disorder after diabetic retinopathy, and one of the common causes for loss of vision. Macular edema, neovascularization, and ischemia causes changes in the retina. And the leading causes is hypertension in patients more than 65 years of age, and younger age group, they say systemic coagulopathy is the main cause. What's the burden of disease? Population-based studies have reported a prevalence of 0.5 to 2% for BRVO and 0.1 to 0.2% for CRVO. The risk factors that I have already mentioned, and as we know. So what are the evidence or what are the clinical trials tell us about the different treatment protocols? BVOS study also in the pre-anti-VEGF era showed us that macular grade laser had definitely improved by 2 lines in 63% of the treated eyes, whereas in the third year follow-up visit there was 1.33 line of gain of visions. It also looked at the role of scatter laser, and it reduced the risk of NV from 31% to 19%, and it recommended that you should do a sectoral laser only after the development of neovascularization. CVR study, however, did not show similar benefit effects, so hence we are using anti-VEGF therapy or the second-line steroids for macular edema. What is relevant today is the role of PRP to address the neovascular complications. PRP was beneficial after the development of anterior segment neovascularization. So coming to the anti-VEGF era, the first line of treatment worldwide as of now, it has shown remarkable reductions of macular edema, improved visual acuity, and also decreased the neovascular complications. Ranibizumab and aflibercept are the 2 most commonly used agents. Off-label use of bevacizumab is also popular. So what are the trials? Bravo and Cruz showed that 0.3 mg and 0.5 mg versus sham in 6 months reduced the central macular thickness and also improved the visual acuity by 16.6, 18.3 and 7.3 lines. Copernicus study showed that aflibercept and sham also had versus sham that there was a 15-letter gain in visual acuity at 12 months of time. Galileo also showed there was a gain in about 60% of the cases, whereas SCORE2 studied the aflibercept versus bevacizumab, which showed improvement of 18.9 and 18.6 letters.
Dr. Saban, could you please summarize?
Yeah. So if you go to the different studies and the real world studies, if you go to it, long-term follow-up, they said 50% of the cases will require ranibizumab treatment after 4 years of onset of the disease. And real-world scenarios by Raja Narayanan et al. Published in BMC Ophthalmology in 21 said that they also had suboptimal visual gain and they had undertreated the patients. Another study published in IGO recently showed that vision improved in BRVO cases, but it was not good for CRVO. So take-home message is there is a level 1 evidence supporting the use of anti-VEGF agents. Ranibizumab and aflibercept are FDA approval, but bevacizumab is equally good enough label. Prompt therapy is indicated because delays may limit visual gains. Treatment should include PRN and treat and extend regimen. Approximately 50% patients will require anti-VEGF therapies after 5 years. Real-world outcomes may not always replicate clinical trials, and so individualized approach should be tried, like steroid-driven approach, a combination of anti-VEGF and steroid, or even macular laser. Thank you for your attention.